Well, good afternoon, everyone. I am Jennifer Schmidt, and I am with the Field Epidemiology Services Unit, which is housed within our Public Health Disease Control and Forensics Pathology Division. I have been with them since 2010, so 13 years, and I've been a field epidemiologist all of those 13 years. And I'll go a little bit more into the presentation as to what a field epidemiologist is. And then I'll also kind of visit with you more and bring some awareness as to why I'm even visiting with this community. So we're doing a two-part series, and our goal here is to meet the needs of clients and bring some program awareness to you and some of the barriers that we in public health are facing with the clients. Oh, maybe. So at the conclusion of this presentation, my goal for those that are able to view it is for them to be able to describe the rising trends of STIs and hepatitis C in North Dakota and the associated substance use disorders. I'd like you to be able to understand the presence of some inherent barriers such as stigma and misinformation that are related specifically to STIs and hepatitis C. And then probably most important for me is for you to become aware of some programs in North Dakota to promote, for you to promote their use to those at-risk populations, such as our syringe service programs, our counseling testing referral sites, and our new innovative program at-home STI self-collection testing. So the national outlook of STIs in 2022, we had 2.5 million cases of syphilis, gonorrhea, and chlamydia. If there's a small little nugget of good news in here, we're starting to see a decline for the first time in over a decade in the number of cases of gonorrhea. Our chlamydia cases are remaining level in the nation, but what is most alarming and most concerning in the nation is our syphilis cases. It is leaps and bounds jumping in the number of individuals that are being affected by syphilis. And then therefore, what we're also seeing increase is congenital syphilis. Congenital syphilis is where we have a mom who is not appropriately treated for syphilis and they deliver a baby. Congenital syphilis can cause birth defects and even spontaneous abortions. And so this is really signaling an urgent need for us to work collaboratively with all of our prevention partners to try to combat what we're seeing in the nation. The next slide that I'm going to move to is a graphic that just kind of shows you a depiction of the nation and what has happened over the course of the last 9 years in regards to syphilis. You can kind of see on the map as it moves from the lighter colors to the darker colors, how we're just seeing this drastic increase across the nation when it comes to syphilis. And I'll play it one more time so you can kind of take a peek. Maybe you focused on North Dakota and now you want to focus on the nation or vice versa, just so you can see it one more time. When I started with the health department in 2010, if we had one case of syphilis, it was an weird year. And now we have way more than one case per year, and you can see the rest of the nation is facing that as well. And this is just something, syphilis is treatable, and so it is something that we're trying to work really hard to bring awareness of this national issue so that we can work together to reverse the trend. In North Dakota, we are mirroring those statistics of the national trends. On the left side of your screen, you can see for gonorrhea, we also noticed a decline over the course of the last 2 years in our gonorrhea numbers. So that is really nice to see. But just like the nation, we are seeing drastic increases in syphilis. Like I previously mentioned, when I started with the health department in 2010, if we had one case of syphilis a year, it was unordinary or out of the ordinary, excuse me. And now we had in 2023 over 200 cases of syphilis. And so it's really alarming to us to watch this giant leap in the number of cases, and we really need to work with our partners to bring awareness and to get this reversed. HIV incidence in North Dakota. Incidence means that these are the individuals that are newly infected living in North Dakota, diagnosed in that year. We're kind of staying even. If you see that we did have a drop in 23, but it's too early to call that a trend. And there are individuals that moved to North Dakota, but they've already been diagnosed with HIV someplace else. Those individuals are not included in HIV incidence. We're really wanting to see this number get as close to zero as possible. And we have the tools available to us today to get that to zero. We have medications called HIV PrEP, where if an individual is on those medications and taking them appropriately, they are 97% effective in preventing them from contracting HIV. And then for those individuals who or have HIV, there's medications that they're able to take where their viral load becomes undetectable, which then that means they are not contagious to anyone. They cannot pass on the virus to anyone else. And so we really want to see that number come down to zero. We don't want to stay, just leveling off that trend. What's really glaring to us in the field epidemiology services is when we are visiting with these cases of individuals that have gonorrhea, syphilis, HIV, there are some very glaring common risk factors that are coming from these individuals. What we learned is from those that had gonorrhea, there were 16% of them that were interviewed indicated they had injection drug use. And then just under half of them report that they're having sex while they're intoxicated or high. When you take a look at syphilis, that number jumps significantly. 26% of our syphilis cases that were interviewed indicated they had injection drug use, and over half of them are indicating that they have sex while they're intoxicated or high. And that's really why I'm wanting to visit with this community. I want to raise the awareness of some of the risk factors that we're seeing for these individuals that are infected with these STIs, because what that tells us is that oftentimes our clients are really the same individuals. When we're having this many individuals indicating that their risk factors are injection drug use, there's something that we can work on collaboratively. And then additionally, as of December 31st, 2023, of all those with HIV living in North Dakota, over 12% of those also indicated a risk factor of injection drug use. Likewise, with those STIs, we also see the same thing with hepatitis C cases. This is preliminary information from 2022 and 2023. It is a vast majority of individuals infected with hepatitis C that are indicating that they have IV drug use. 76% and 68% respectively in 2022 and 23 indicated that they had injection drug use. When you filter out and just look at those individuals that are 35 years of age and younger, that number jumps to over 80. And then 1 year, it was 90% of those being diagnosed with hepatitis C in North Dakota. They are indicating to us that they have injection drug use as their main risk factor. And so it's because of this information that we are aware of that we wanted to bring awareness to this community of the things that we are seeing, so that we can work together to bring these numbers down. And how you do that is through awareness, education, and then making sure that you're aware of, we know there's a problem, but we also have programs available to help. And so that's another part of what this series is about. Some of the things that so you might be asking yourself, like, how do we know this information about these individuals? And on the left-hand side of your screen, you're going to see a map of North Dakota. And that is where we have 10 field epidemiologists that are regionally located across the state. They live in or near the regions that they serve, so they are members of the community, and they are responsible for each of these counties. They are the primary investigator for these infectious diseases that occur within those counties. And so on the right-hand side, I have a list of our mandatory reportable infections. There's just under 80 diseases listed there. that are required by law to be reported to the health department. And it's these field epidemiologists that are your primary investigators. If you recall back during the pandemic, you might have heard of contact tracers. Field epidemiologists, some of what they do is similar to that, but it's much, much larger than what occurred by a contact tracer. But just to kind of give you an idea of what their role is, we call them disease detectives. What they're doing is really trying to link people into care, but also to identify whether we have an outbreak that we might need to make people aware of as well. So while the field epidemiologist has an individual on the phone, we do investigate all reports of gonorrhea, syphilis, HIV, and hepatitis C. And during those investigations, we're obtaining clinical information such as, did they have any symptoms? Did they get the right treatment? Did they have the right tests done? Do they need to have some follow-up testing done or some confirmatory testing done? Our field epidemiologists are working with the clients to ensure that their health is being taken care of. Also, a part of that investigation then is that risk history. That's where we are soliciting that information as to if what are their risk factors. And that's where we're gathering for the injection drug use or having sex while they're intoxicated or high. I do want to note that an individual can decline that survey. It is voluntary, but we definitely do use that information to bring awareness where we feel it is needed. So we do appreciate everyone's cooperation with that. And of course, it is anonymous information. We keep it highly confidential. Another part of the investigation is for us to identify contacts. So in this sense, when a person has an infectious disease, at some points in the infectious disease, they are contagious and they may have spread it to others. And so we work with the client to find and determine who would be best to be referred in for testing and treatment if needed. And if the client themselves is not comfortable telling their contacts that they may have been exposed to this, a service that we provide in field epidemiology is that we can do that notification anonymously. We can call that contact, we can visit with them, let them know of their potential exposure and where to go, and it's all done confidential. So if someone is not comfortable letting their own contact know, we are able to do that. And probably the thing that I'm most proud of in our investigation is that we're able to make referrals. So while we're visiting with someone, we may, we're soliciting those risk factors, we may learn that they are a wonderful candidate for HIV PrEP, but they don't know where to go. Maybe they don't have a primary care provider, or maybe they don't want to talk to their primary care provider about their sexual health. We have, with that team being located regionally throughout the state, we know where to recommend people to go. We are comfortable, yep, this is a great provider for that, and kind of talking them through those referrals. Some of the other things that we are beginning to make referrals for assistance, if you will, is when we're being told that, I have a substance use disorder and I am interested in getting some help. We are beginning to do some of those referrals as well, just at least giving them an arrow of which direction they should head for that help. That's not our lane, so we definitely are not experts, but we are assisting as much as we can, and we're really making sure that continuum of care is there. As I mentioned with the clinical information, sometimes we find out that they weren't appropriately treated for whatever infection it is that they have. We are the safety net that works with that continuum of care. We're going to work with that healthcare provider, letting them know we need to adjust the treatment for this client. And so we really do follow them throughout the whole process. What is kind of fueling this trend that we're seeing in the nation is some inherent barriers that are just a part of what we deal with. And one of the larger barriers that we are aware of is our healthcare providers are not comfortable asking about sexual health questions. What we hear from our healthcare providers is they'll say, the patient will bring it up to me. If the patient has questions about their sexual health needs, the patient is going to bring that up. And That is not correct. That is not a mindset that we want for our healthcare providers. The mindset should be we need to ask these questions. We need to inform our clients and our patients as to why we're asking these questions. We need to normalize these sexual health questions so it becomes a comfortable conversation for both, not just the patient, but also the provider. And so we don't want healthcare providers assuming that the patient's going to bring it up to them. We want the healthcare provider to become comfortable and bringing it up to their patient. And so we are working to educate providers. We have toolkits available to them. We have little flip cards and things like that. And we offer trainings to get our healthcare providers as comfortable as possible with these sexual health questions. Another barrier that we find is just our clients themselves. They're embarrassed, to be honest. Maybe they have a primary care provider, but we live in a rural state. Maybe they see their primary care provider at the basketball game each week, and they're not really ready to tell them everything, even in the confines of that private office. So that's just another barrier that we're having to deal with. And then the culture of North Dakota. We're a very proud people, and we're a very private people, and so sexual health conversations, it's private. We don't really talk about that, and so that culture is really difficult for us to break down as well. And then the mentality of we're proud and we're strong and we take care of ourselves. So that culture surrounding asking for help, especially with addiction and mental health services, that we just see that barrier occurring when we're visiting with individuals. And what happens then when we're suggesting to folks some of these harm reduction strategies and meeting people where they are, that culture that's been ingrained in clients can kind of stop them from reaching out to programs like syringe service programs and that medicine assisted treatment, because there's just that, no, I need to help myself. I need to do it cold turkey. I have to, do it the right way 100% of the time. There's not that let's meet you where you are mentality. And so those are some of the barriers inherently that we are working to break down. Additional to those, there's also the barrier of public health to behavioral health. As I mentioned, when we're field epidemiologists are visiting with individuals and they indicate that they have a substance use disorder and they're interested in learning more about getting help, we don't know always where we should send them. There are great tools now to kind of help us sift through that, but still we might not be that comfortable in letting people know where to go. And that's something that as field epidemiologists, we're all about uplifting people and empowering people to get to be the best person that they can be. And if we don't know where to send them, we don't really feel comfortable with that. So that's definitely a barrier. And then vice versa. For our behavioral health professionals, if you have a client sitting in your room and they're like, I'm worried that I have hepatitis C, my buddy just told me, is the answer that you say to them, well, talk to your healthcare provider about that, which that's a good answer. That is a great place to start. But what if they're not comfortable talking to their healthcare provider about their injection drug use? Or what if they don't have a primary care provider? Where should behavioral health send these people? And so that's another inherent barrier that we see. And we want you to feel comfortable reaching out to public health, reaching out to your field epidemiologist. So we can answer those questions for your clients. You don't need to be the expert in these infectious diseases, but we hope that you learn who is in your area so that you can reach out to them as you need. In addition to barriers, we also fight misinformation or misconceptions. When we are visiting with clients that have been newly diagnosed with HIV, some of the things that we find out, they may have known that they were at risk for HIV, but they just put it off, going in to get tested. And so what we learn is that it's kind of an ignorance is bliss. It's a death sentence for them, they think, and they don't want to know. So if they don't know, then they don't have to face it. And that couldn't be any further from the truth today. HIV is not a death sentence. We have wonderful medications available and they are affordable. In some ways, HIV is more manageable than chronic diabetes. So it is definitely a major misconception that we have, and that HIV only affects a certain sexual orientation. And that couldn't be any further of the truth. We have all genders, all sexual orientations living in North Dakota that are affected by HIV. So those are some other things that we have to combat when we're visiting with individuals. And specifically to hepatitis C, a lot of what we hear is that the medication is too expensive and that the client needs to be clean. And these things have changed. That used to be true, but no longer is that the case. And my colleague in part 2 will go a little bit more into why that is no longer the case. In addition to the clients themselves and the healthcare professionals, we also deal with misinformation in the public. So one of the things that we have been trying to work on is sexual health education. And there always has been a hesitancy to how much sexual health education should be in schools. There's always been a little bit of a, ooh, this is kind of a taboo subject. How much should we talk about? But it was done, and it was completed in our schools, and we're seeing more policies and more pushes from groups such as the Family Policy Alliance, indicating that sexual health education should be done at home. It shouldn't be done anywhere else but home. And not that we disagree with that, but what we find is that it's not happening at home. You're going to have some parents that are comfortable with it and they do share information with their children, but you're going to have a vast majority of parents that are not comfortable talking about sexual health, or that they have the knowledge to be able to really fully explain and teach sexual health education to their children. And so this is something that we're seeing a backlash to, if you will, because so here we have a cohort of students that are coming of age with zero or next to zero sexual health education. And then we have this alarming increase in STIs across the nation. And so that's kind of fueling that rise as well, because they may not realize that they're at risk and that they should be tested. We also see misinformation related to the harm reduction services, such as syringe service programs or SSPs. And so we have to spend a lot of time and effort in educating and combating those myths, such as like SSPs do not increase needle litter, they do not drive up crime rates, and they do not enable drug use. There is lots of research and best practices out there, and that prove that these SSPs, they don't do any of that. But there's still a lot of fear associated with SSPs because of those myths, thinking that it would enable more, it would cause more drug use, and that couldn't be any further from the truth. So these are some of the things that we have to combat and fight in order to work together to bring down that number of infectious diseases. So speaking of our syringe service programs, or SSPs, I'm going to just touch lightly on it because there will be a little bit more of it in part 2. We have 5 located in North Dakota: Fargo, Grand Forks, Mandan, Minot, and Valley City. And what I wanted to make sure that this community was aware of is that these 5 locations, they were chosen by the county themselves. The state provides guidance for counties that want to have an SSP, but it is ultimately up to the county themselves to initiate the SSP and continually manage the SSP. So it is a county-based decision that happens with guidance provided by the state. And other than the syringe service program, the syringe exchange piece of the program, really what's important to know about these is that it's a linkage. It's a linkage to care. It's meeting people where they are, that harm reduction strategy, and finding out what's their need. Do they need food assistance? Are they needing housing assistance? And those linkages to those other services are provided by our SSPs throughout the state. Another harm reduction strategy that we have is our counseling testing referral sites. Those are our CTR sites, we call them. There's 25 located throughout North Dakota. Most of them are housed in our local public health units, not all of them, however. And what our CTR sites do is they provide free or reduced cost HIV and hepatitis C testing, and it's all confidential. So if you have a client who, let's say they have health insurance, they have a primary care provider, but they're not ready to tell their primary care provider that they're a person who injects drugs, but they do want to know their status for hepatitis C and HIV. We strongly encourage you to refer them to one of these CTR sites so that they can have a confidential test done, and then they know what their status is. Some people who we would strongly encourage you to refer to our CTR sites, in addition to the person who injects drugs, is individuals with multiple sex partners and men who have sex with men. All right, the next piece that I want to go into is our brand new program. It's our at-home STI self-collection program. We're very proud of this program. It is one of a kind. There's no other jurisdiction in our nation that is offering a comprehensive at-home STI self-collection and free. If you were to Google at-home STI testing, lots of things will pop up. But number one, it won't be free a lot of times. And then it's not going to be comprehensive. And what I mean by comprehensive is, and I will go through that as I finish up these slides here to tell you more about this really innovative program, is that we do a lot more tests that others don't. And when a client gets their results, we have a North Dakota medical provider that can meet with them via telehealth to help them to know what to do with those results. A lot of those if you were to Google and click on, if you do any of the testing, you get the results and then you're on your own. And that is not what we wanted for our program. We wanted that continuum of care to be a part of what we do. And so we did make sure that we did that in our program. So as I mentioned, we have those CTR sites across the state. And that what we did here is I have this map, and what we found is that 30% of North Dakotans live more than 20 miles away from a clinic that offers comprehensive sexual health care. And so we have a lot of North Dakotans that they don't have easy access. And so we wanted to fill some gaps that we have identified, that being one of them, of that travel burden that we have. We also wanted to reach people who feel stigmatized. Maybe they're not comfortable for whatever reason. That can be a barrier. We wanted to reach those individuals. They may want to take care of their sexual health, but they just didn't feel safe as to where they could go to share that. We wanted to reach those people that were unable to pay, and especially those people that were not comfortable talking about sex with their healthcare provider. We also wanted to have an avenue to be able to get partners tested and treated. Sometimes that's a huge prevention piece, is when we solicit those contacts from individuals with infectious diseases, we get that partner information. Sometimes there's a pretty large barrier for that partner to go in for testing and treatment. It can be transportation, it can be financial. We wanted a positive solution for them to go ahead and take care of their sexual health needs. And then we also wanted to offer a gateway to HIV PrEP services. So what we field epidemiologists know is that there are pockets within the state of North Dakota where we do not have a healthcare provider that is comfortable prescribing HIV PrEP for whatever reason. And so we wanted to make sure we had available a way for everyone in North Dakota, if they want HIV PrEP, and access to a healthcare provider that could do that for them. And that is a huge goal of this program, is to go ahead and increase that gateway and allow people that want access to be able to get that medication. So this great grand idea of at-home STI collection came about in 2020, 2021. But the question was, will people like it? Will people want it? And this was prior to self-testing at home, like a COVID thing or anything like that. And so we did a needs assessment, and we did find out that overall they felt like North Dakotans would be receptive to this type of care, and they really felt during that needs assessment that this type of program would be very beneficial to those living in rural areas, who maybe they have a primary care provider, but they're just not comfortable discussing their sexual health needs with that primary care provider. So we needed to get the word out. We primarily advertise this at-home program through social media, such as Facebook, Instagram, YouTube, TikTok, and Snapchat. That's our main place that we promote. That's one of our online advertisements that you can see there in the top, in the right half. It's the top left. That's a pretty common advertisement that you'll see on those social media sites. We also advertise on the social networking or online dating apps such as Grindr, Tinder, Adam for Adam, and Scruff. And then, of course, we rely on grassroots effort, that word of mouth. A client likes it, so they share it with their friends, or like today, I'm sharing it with this community in hopes that you will share it with your clients as well. And then we partnered with the Health Equity Office at North Dakota Health and Human Services, and they helped us create a couple of these posters, one targeted towards our American Indian population, and the other targeted towards our new Americans, foreign born, and immigrant liaisons. And then, of course, our field epidemiologists also do a wonderful job of getting the word out there to people so that they know about the service, and use it if they would like. So what happens is when somebody clicks on that advertisement, or they scan a QR code, if you will, or follow a link that's been provided to them by one of our field epidemiologists, this is the landing page where they're going to go. This is a website that was created by Binks, who is now I'm Aware, is the name of the company, and they are a vendor that we work with directly. And this landing page is specific to North Dakota. A client then clicks on Find Your Test, and when they get there, they click Get Started, and they need to answer sexual history questions. And why we do that is there's actually 5 different boxes available, and we want to make sure that the person is being sent the most appropriate box for their needs. And also those boxes and that questionnaire that they answer is being reviewed by our medical director, to kind of have that double check to make sure that the right box is getting to them. The box is then shipped to them very discreetly via UPS to their North Dakota address. So we have 2 qualifying factors to be able to do this. You do not have to be a North Dakota resident, but you do need to have a North Dakota mailing address. That's how we're able to provide it for free to those people that are living in North Dakota. And the other qualifying factors that you need to be 14 years of age and older. As I mentioned, this box is discreet. I've had individuals tell me that they forgot that they even ordered it, and they thought it was just another something from Amazon that they ordered. And then come to find out, they're like, "Oh, this is that test kit that I ordered." So it's extremely discreet. Most people have no idea what's arriving at their door via UPS. Once it gets to their door, the client activates their box. There's a few more questions that they are asked, and then they can begin the self-collection in the privacy of their home. I will mention that this is not like a COVID test in that you do one swab and then you sit and wait. There are multiple steps involved in this, so you do need to assign about 20 to 30 minutes to go ahead and do the self-collection. When the person gets the box at home, there are tutorials and informational flyers in the box to kind of help you through, and nice pictorial graphs to guide somebody through the testing process. And if they're still not really sure about that, our vendor also has QR codes that they can scan, and it'll take them to online videos that will walk them through that self collection as well. And if that still isn't enough, there's actually a customer service number that is manned by our vendor that then an individual can call and ask for assistance as to, if what else they need for collection. Then the person puts their samples into a prepaid envelope and they drop it into their nearest UPS drop location. Now, yes, we know that there are some areas in North Dakota that don't have a UPS drop location really close by. And so if that's true for that particular client, they can ask, they can inquire for UPS to actually come to their house and pick it back up. Again, the package that they're putting it in is very discreet, and most people have no idea. It's just a regular old package that gets sent back. And then in an average of 7 days, the client will have their results. The results are available to them in a patient portal. So during that ordering process and then that activation process, the individual is in their own individual patient portal, similar to a MyChart, if you're familiar with that with other healthcare systems. And it's within that patient portal that they will receive their results. And they also receive email notifications as to like where their samples are in transit. It's at the lab, it's being tested, it was shipped to your house, and so on and so forth. They're going to get email notifications, and then they'll also get that notification of their results. So as I previously mentioned, there are 5 different boxes that we have available, and that is what's very unique about the program in North Dakota. And on the left-hand side of the screen, I have images of the actual box and what the contents of the box looks like. So for those 5 boxes, every single box has tests for individuals to be screened for HIV and syphilis. And then dependent upon those questions that they were asked and how they answered will determine what kit they get for their testing. Everyone is tested for chlamydia and gonorrhea as well, but some people only need a single site screening and some people need multiple site screenings, such as genital, anal, or oral screenings for chlamydia and gonorrhea. Then for those individuals that indicate they're a person who injects drugs, we would recommend that they be screened for hepatitis C. And then, as I mentioned, we wanted to provide a gateway for HIV PrEP medication. And so we have a PrEP starter kit. And to be on PrEP, in addition to the STIs, we also, the medications require an individual be screened for hepatitis B and that their creatinine levels be checked. And so that is also included in that PrEP starter kit. So these are the 5 boxes that are available for those clients. So, like I said, when a person gets their results and it'll come in their patient portal, if they have a positive result to any of those infections, our medical director, which is in North Dakota, is going to reach out to them and set up a telehealth meeting. And so they're going to have a telehealth visit and they're going to discuss those positive results and what the person's preferred next steps are. So if they have a chlamydia infection, do they want their prescription written to their local pharmacy? Or, you know what, we have an ability to be able to send it to them free through the mail. Would they prefer that? For gonorrhea, we would prefer that an individual actually receives an injection. So our medical director will work with the client to find out what's the best place and most cost effective and the one that they're most comfortable with going to get that injection. And then for those individuals that have positive HIV, syphilis, Hep B, or Hep C labs, those need some confirmatory testing done. And the medical director and or our field epidemiologist will work with the clients to get them to the best location for them to receive that continuum of care. And this is a big piece of the puzzle that a lot of the other programs that are out there, they don't have. So like I said, if somebody were to just Google at-home testing, they could test themselves, but this piece of this treatment coordination oftentimes is not included. And so that's why we really strongly encourage you to be aware of this particular program and advocate for individuals to use this program. So if you have a client that's coming to you and asking you, hey, I had this ad pop up. Is this real? Is this legit? It says it's free. Yes, it is real. It is legit. It's confidential, and it's a really great service. So feel comfortable going ahead and saying, yep, that actually exists in North Dakota, and I think you'd be a great client to use that. So some questions that we had to make sure that this program was working because it's innovative. And as I mentioned, there's no other one like it in the nation. We, at the beginning of the implementation, we were wondering if we would actually be screening clients that were at risk. So this tool, this advertisement is out there on our social media, and where we were worried that we'd have like the worried well or just the curious asking for these kits. And so it definitely was a major concern. And so we keep track, and what we found is that yes, we are finding the people that are at risk. So these numbers, this percent positivity, we are either at or above the national average for what you want to see when you're doing your testing. How many positives do you want to find amongst your population? And so we definitely are reaching the at-risk population, and we're really happy to see that. We also wanted to monitor to make sure that we were being equitable. Were we reaching the LGBTQIA plus population? Are we reaching racial minorities? And yes, we are. 45% of our clients are men who have sex with men. And actually, the minority groups per 100,000 order more of these kits than our white, not non-Hispanic residents of North Dakota. As I've mentioned kind of throughout, we really wanted to increase HIV PrEP usage across the state because we want to see that HIV incidence go down to zero. And so are we getting new people signed up on HIV PrEP? Yes, we definitely are. Each year we're seeing people who didn't know about HIV PrEP, or if they did, they weren't really sure where to go. We are always seeing new people start HIV PrEP, and that's something that we're really proud of. The other piece that we want to keep track of and we kind of monitor is that rural North Dakota. Are we seeing people who we thought needed access to this type of testing and confidentially, and are they using it? And what we found is yes, they did. When we take a look at our rankings per 100,000 population, we actually had Steele, Griggs, and Logan counties leading the pack in the number of kits that are completed. And so, yes, it is being used by small town, and we're really happy to see that. One of the things is hepatitis C, however. We would like to see more individuals that are at risk for hepatitis C utilizing this program, and that's just one more reason why I'm visiting with this community today. So in 2023, we had 560 clients use the at-home STI self-collection program, and of those, just under 4% indicated a risk for hepatitis C. And of those individuals, just over half of them did go ahead and allow asked to be tested for hepatitis C. So we would like to see that number rise. Not that we want to have more people at risk for hepatitis C, but we want to be able to, those individuals that are at risk, we want them to know that there is availability for them to have confidential testing. And so we really wanted to bring awareness specifically to this community about this program, and that hepatitis C testing can happen in the confines of somebody's home and the privacy, and so that it's confidential and maybe just a little bit more comfortable for them. So when we asked our clients why they chose the at-home testing program, overwhelmingly for the first 2 years, everyone says it's because of the privacy of testing at their home. And then it's followed up by kind of flip-flops between they can't afford testing or they don't have time to get tested. And then we see it rounding out to I'm not comfortable discussing sexuality with my healthcare provider, they don't have health insurance, or they're not sure where to get tested. So overwhelmingly, people that choose this program, it's because they want the privacy factor in their home. What I can tell you is that the clients that find out about this program, they love it. They love, love, love this program. And so I just have a couple of quotes for you, some of the things that we hear from patients. One of them says, I'm so thankful for this program. I didn't have to drive over an hour to the nearest health unit that offers testing. I wasn't comfortable going to my small town clinic for my STI test as I know the nurse. This was from a 60-year-old female in Northeast North Dakota. Another comment we received was, we are a married gay couple that is not comfortable using our local clinic as they are anti-gay. With this program, we are both on HIV PrEP, and Heidi found a way for the PrEP medicine to be mailed to us as our local pharmacy didn't routinely keep it in stock. Heidi is our medical director based out of Fargo, North Dakota. And just some emails that we've received is thank you so much for the service. And do you guys take no donations for the service? I don't know about you, but I don't know very many government programs that get asked if they would take donations. So that just kind of touts a little bit of how people really feel about this program once they find it and they start using it. And with that, I will stop sharing my screen and open it up for any questions. And for those of you that are maybe reviewing this as a recording, my contact information is there, and I'm happy to answer any follow-up questions. And also remember that there is going to be a part 2 of this in a couple of weeks, and there my colleague is going to talk much more in depth about hepatitis C treatment and HIV prevention.
Thank you so much, Jennifer. Does anybody have any questions?
I should mention that if it's something that you're interested, we have flyers, we have postcards, because I know the links for it were kind of quick embedded within the publication. So if you want some postcards at your facility to hand out to clients, or you want a flyer to hang up, we have all of that available. In the flyer like has the QR code. So please just let us know, and we're happy to share those with your different facilities. And Allison, I will share with you a flyer that you can then send out to some individuals that you felt would be impertinent. It will be for your field epidemiology contacts. And on that, it'll also have a QR code to scan for the CTR sites in North Dakota, and then also the at-home testing program. So I will send that off to you later today.
Awesome. Well, if there are no questions, Jennifer, I always appreciate your time. I will get this recorded. It's recorded. I'll get it up on our website. But Sam, Melissa, Alexis, it was great to see you guys. I'm glad you could attend, and hope to see you at part 2. All right. Bye, everybody.